So I farm so hard, the employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go A's. Never wanna see another B unless I'm Jay-Z. Farm so hard.
What's up, fam? It's your host, Jim Pruitt, aka PharmD and the ED, and I bring you another episode of the Pharm So Hard Podcast. You know how we do it. We have a special episode. We have some cool stuff, and this is part of our Talks Month. You guys can get lucky. You're gonna get to skip one of the experts in the field talking to you about the topics that you guys chose online. You guys chose, you want to hear toxic alcohols. You guys want to hear a lot of these things. So let's go ahead and jump into this episode. But before we do that, we got to let our guest introduce himself and tell us a little bit more about, because it's going to be a great episode.
Hey, thanks, Jimmy. My name's Thom Maciulewicz. I go by Thom Mac. It's a lot simpler with a lot fewer letters. I'm originally from the Northeast up in New York. I found myself where I am right now. I'm down in Arizona. It's a lot warmer here, a lot more snakes, a lot fewer squirrels. And so I just finished up my toxicology fellowship in June. And right now I'm hanging around to do more stuff with snakes. So it's really exciting to be here. And thanks for having me, Jimmy.
Oh, thanks. I feel like this is a long time coming, so super excited to get this going. Before we jump into it, though, again, always got to make sure we get some of our announcements out of here. Of course, you guys have been to the Empower RX conference that happened in May. That was phenomenal. We're already in works and planning the next steps. If you guys are interested in joining our committee, if you guys are interested in going back and reviewing the last 2 years of what we've created, go ahead and visit empowerrx/conference.com and check us out there. And for those that are moving forward and just saw everyone get BCEMP certified or BCCCP or BCPS, all those extra commas behind your name, you looking for stuff like that? Let us know. We got some stuff like that at PACU.com, and we can really help you guys out from a board certification prep standpoint. But again, let's go ahead and jump into the tox world and talk about toxic alcohols. Again, a topic that just isn't interesting, but vital for everyone. Again, emergency medicine, toxicology, intensive care. Again, we're going to be joined by an expert that's going to lead us into this, but let's go ahead and transition. All right, so let's go ahead and jump into some of the background with all this. Great to have you here, but let's set the stage. Can you give us a basic overview of what we're dealing with when we say toxic alcohols? People say those terms, but realistically, not all of us know what that means. So what makes them toxic, and how do they generally affect patients?
Yeah, so toxic alcohol is really any alcohol, even the stuff, when you go to the corner store and you grab a beer, or you go to the bar and you get a drink, ethanol, that's still a toxic alcohol, right? It has an effect. It makes you feel inebriated. If you have too much of it, you can certainly meet your demise. But in the world of toxicology, typically when we're talking about toxic alcohols, we're referring to substances that are not intended for consumption. We think of things like methanol, ethylene glycol, isopropanol. And these can be found in products like windshield washer fluid, cooking fuels like sterno, paint removers. People have been known to inhale large amounts of things like carburetor cleaner or drink antifreeze. There's rubbing alcohol, like all these things that you can find. And so we're not supposed to be drinking these things, and thus we have some toxic effects from these. And really the hallmark toxicity of these substances is typically a metabolic acidosis with a high iron gap. And this is due to an accumulation of organic acid and ions. Patients can generally be affected in various ways, and this depends on the offending agent that you have, whether it's methanol, ethylene glycol, or isopropanol. And it can really go from a severe AKI or renal failure to life-threatening cardiovascular or CNS complications. So big topic.
Yeah, tons of different stuff on there. And I think that, again, setting that background for us really helps us out. But when we start thinking about a deeper dive into the specific alcohols, you start to get into the particular ones. And I think all this is fascinating to see the diversity and how these toxic alcohols can present. Now, let's say, again, we start thinking about the specific ones like methanol and ethylene glycol and isopropanol. Can you kind of dive a little deeper into each one of these and how they can manifest in our patients? Because again, there may be some particular differences. Again, an expert would know.
Yeah, sure. So these things can be complex, and they've been pretty well studied over the past decades. And so I'll give you some general things, and I'll give you a couple specific things, but just know there's a lot of a lot of weird and strange things can happen with these exposures with outcomes. But we'll start off first with methanol. So this gets, when we say these toxic alcohols, it's usually not the parent compound that's causing problems. It's what it gets metabolized to. The toxic metabolite is the culprit, really. So when we start with something like methanol, we have alcohol dehydrogenase that, converts it over to formaldehyde, and then we have aldehyde dehydrogenase, and this gives us formic acid. And this is the culprit that causes the hallmark metabolic acidosis. And depending on the pH, where you are in this toxicity and how it gets, consumed and metabolized, the more acidotic the patient is, the more you get this dissociated form present, which is our formic acid, versus, formate, which is undissociated. So when we have these people, you'll hear about some treatments. I know you hate bicarb, right? It's like always like bicarb is trash. So this is one of the the points where you might start bicarb drip. So what it does is it's going to alkalize, and you're going to get that pH back up. It's going to trap the formate into the blood, or essentially pull it away from the tissues as best it can. And that's because formate in itself, even though it's, you've gone from formic acid to formate, that in itself is still toxic. It can uncouple oxidative phosphorylation over cytochrome C oxidase, and it has, other really wicked effects of visual impairment, the snowfield vision, or complete blindness. And some of this, when we talk about the visual effects, can be immediate, or when I say immediate, within a few days of exposure, or it can happen chronically. So this can happen and push out from weeks to months. I've had patients that come in that have been chronic methanol exposures, and when they come in, they will report some changes in their vision acutely. I've had other patients that don't. So it's really different on that forefront. So this pathway is a gnarly, crazy one. But one of the theoretical things we can do that has very little risk to it is give folate IV. And typically we do about a mg per kg up to 50 milligrams Q6 hours. This is thought to help kind of process the formate to CO2 in water. But like everything else in tox, there's not a lot of data on it. We do it because the risk is low, and the benefit is, hey, we'll take it in these exposures because they're pretty serious. Also with methanol, there's been historically a high rate of pancreatitis, some reports up to 50% associated with this toxicity. So you should be checking lipases and LFTs in these patients as well. But the big concern and the big worry that has me always really worried big time is with methanol, you can get really pretty severe CNS toxicity. What I'm talking about is basal ganglia lesions, necrosis and herniation of the putamen, and even intracerebral hemorrhage. We just had a case this recently, a couple days ago. Patient had a massive methanol exposure, and he went, straight to this pathway. These are, you can't fix brain tissue. Once it's damaged like this, you're done. So that's kind of my overall scope of methanol. We'll go through some other things later on, but I want to just kind of give you the general where it can go and start from. And now we have ethylene glycol. And so alcohol dehydrogenase gets that to glycolaldehyde, and then aldehyde dehydrogenase gets you to glycolic acid. That gives you a metabolic acidosis as well. It's further metabolized to oxalic acid. This binds up calcium in the system, and this forms oxalate crystals that can be found in the kidney. This is what leads to an AKI in these patients. And you will also see some calcium oxalate crystals on the UA from time to time. This isn't a diagnostic feature to show up, but if you don't see it, it doesn't mean it's not happening. There's been death cases, where in these fatalities where they do autopsy, they find oxalate crystals in the brain, the heart, the kidneys. They find this stuff everywhere in really bad cases. So yeah, that's pretty bad. And then, I talked about folate. There are vitamins and things that we can do in ethylene glycol exposure. So B6 or pyridoxine, magnesium, and thiamine in theory can help shift the metabolism of glyoxylic acid to a less, toxic metabolites that can be, eliminated renally. It's once again, with the other stuff, it's very little risk, potentially helpful. I usually do B6, 50 milligrams, IV Q6, thiamine, 100 milligrams daily, and then I do magnesium 2 to 4 grams IV daily as well. One of the more interesting pieces with ethylene glycol exposures is the glycolate metabolite can also cause a falsely elevated lactate. And this is due to the lactate oxidase enzyme that's used in a lot of blood gas analyzers. I've had, these double digit lactates where they come in, they're like 15, 13, 16. You're like, wow, what do I have in front of me? And this patient doesn't look too bad. I mean, they look, like they're out of it a little bit, but for that kind of lactate, no. And so, what you can do is you can check it on a different analyzer. And what you can do is you can do it with there's an enzyme called lactate dehydrogenase enzyme assay. Instead, you can call your lab, they'll be able to tell you what enzyme they have in their machine, and that'll kind of help you determine if the lactate you're looking at is real or not, and if you're in the case where you have these exposures. As far as other manifestations from oxalate, this can, because we're binding up calcium, hypocalcemia, this can be, present in some pretty big exposures. So it's probably worth getting an ionized calcium in these patients as well. And the other thing to watch out for with profound hypocalcemia is that you get this prolonged QT interval. Okay. And now we're talking about going into ventricular arrhythmias that are pretty bad. Other considerations is you can get cerebral and pulmonary edema. And I've definitely had seizures. I've definitely got bedside to do checks on patients, and I'm doing like grip strength. And, while they're grabbing my hands, they start seizing. Scare the hell out of me. But yeah, some weird things can happen with these toxic alcohols. They're all very different. You talk to, 100 different toxicologists, they're going to give you 100 crazy. So that gets metabolized by alcoholic dehydrogenase as well. Acetone gives us this, which is the metabolite, gives us this very classic ketosis without acidosis picture. And this is pretty diagnostic for these exposures. These are pretty straightforward. These folks will likely be very inebriated and drunk in your ED. And this is due to, when you look at these alcohols, the more carbons you add to these structures, the greater the CNS penetration, the greater the inebriation effect. So people with isopropanol, they'll be very inebriated, and even with ethylene glycol, they'll be fairly inebriated as well. Actually, probably twice as inebriated as with regular ethanol alcohol. But when you get these methanol patients, they may not appear as inebriated. They may be a little more groggy. They may be a little more clairvoyant at times. So there's a wide spectrum you can get with these folks. But with isopropanol, it's common to see GI upset, and hemorrhagic appendix does occur as an irritant to the GI tract. So just keep an eye out for that. And a few other things to watch out for is if you can get a falsely elevated serum creatinine. This is due to acetone basically interfering with colorimetric JAK reaction, and so you get this falsely elevated serum creatinine. So really just pay attention to the patient's urinary output is an easy quick fix for that. My big things for these patients is they just really need excellent supportive care. So I just ensure they get resus with plenty of IV fluids, and throwing things in like PPIs or H2RAs to help with the GI upset work really well with these folks as well. But like I said, you got 3 different toxic alcohols that their toxicity can really widely vary depending on how much and where they are in their presentation. But just also keep in mind that a lot of these folks are pretty severe alcoholics a good proportion of the time. So keep in mind that you may be dealing with a potential rip-roaring metabolic acidosis in the future, but keep an eye for for those folks that aren't getting into that, they're going to have some alcohol withdrawal. So just make sure you're monitoring for that.
Yeah, I think that's a good point you bring up, and it's like you really went into not only just the kind of the background of some of these alcohols and some of the pathophysiology, but you also in that same time really talked about the clinical presentation of all of them. So I think like you really kind of honed in on the difference between the methanols and ethylene glycol and isopropanol. It's like all these different ones present slightly different. I think the casual ED person, we just think of them all together, but it seems to be some variabilities. And I think from the patho standpoint, that's where, tox is just a cool specialty. Like you start getting into some of the patho and the toxicology, it just makes it pretty freaking cool. So I won't dive deeper into their clinical presentation because you really kind of honed in on that. And you mentioned some treatment, but I really want to kind of take a moment to really dive down these things because, again, I always say I hate bicarb except for tox. So tox got all the love for me because it makes sense. When we do things just because we think it fixes a number, that's one thing versus like, oh, from an actual clinical standpoint, we're going to make the patient going to improve and we're actually doing something. So again, the bicarb is safe in toxicology. Your benzos and bicarb are safe. So let's kind of transition now into the treatment approaches. You make some really good points about that, but I want to kind of get a little deeper and really kind of honing in on each one of these things in a pharmacologic standpoint. And can you kind of share your approach to treating these alcohol poisonings and what do the guidelines say about these things? So again, we can really go back and really just say, okay, we found what it was, we've diagnosed it, now it's time to do something about this. And what will be that mindset you go into, and give us some resources to kind of help us treat these sort of a casual ED person.
Yeah. So, the first thing I like to do with these folks, whether we're aware that this is or confirm that it's an actual toxic alcohol that we have in our hands or not, the first thing I like to do is resuscitate these folks with IV fluids. I bolus them, start some maintenance fluids. These folks are usually dehydrated, they're volume down, and this is either from decreased intake or the increased output, from vomiting and whatnot. So the first thing we like to do is get fluids in them and start there. For labs, the first usually jump into is, for very basics, is get a BMP, get an ethanol, and then get an osm. And we're doing this so that you can check an osm gap. Make sure all these labs are drawn at the same time. That's also important for this process. And then you're going to initially trend these things Q4 hours to see which way the anion gap and the osm gap are trending. Knowing this is not the greatest sensitivity specificity, sometimes it's the best we have, and I'll go on to that a little more further on why. These are simple tests or cheap tests, and we can get these typically in most spots. But in a toxic alcohol, if you're early on in your course and you see a high osm gap and a low anion gap, as time passes, that osm gap will drop as the toxic alcohol is being metabolized to that toxic metabolite, the thing we're really worried about, and the anion gap rises. So that's why we're kind of trending these basic labs, and that's where we're looking to see where things go. If you can, get a VBG and a lactate in these folks as well, and consider an ionized calcium if you think you may have an ethylene glycol exposure. So what I was alluding to earlier is we can get into okay, let's go get levels. Let's test for the toxic alcohols. So we'll talk about that. So you want to grab what's called the volatile panel, and that measures for ethanol, isopropyl alcohol, and its metabolite acetone. And then you're going to get, for a separate test, an ethylene glycol is done via gas chromatography. Now, depending on your institution, they may kind of lump both these tests together in the same order set, but keep in mind that the ethylene glycol test is different. There are ethylene glycol tests that are done by immunoassay, but these have a lot of false positives that occur with these. We want the gas chromatography. So when we talk about these labs, not many places can do these anymore. They typically are send-outs, and they may take a week or longer to result. I mean, here in Arizona, I've had toxic alcohol panels sent out, and they've been sent to North Carolina, they've been sent to Montana. It just depends on the health system and where they send things and where they have labs drawn and what they have contracts with. Versus, if I'm at my institution, we can get a turnaround usually between 12 and 24 hours. But still send one, especially if you're going to be starting antidotal treatment, which leads to, okay, how do we treat these folks now? Like, what's the antidotes? What are the treatments? So what we're trying to do is we're trying to block the conversion of the parent alcohol to the toxic metabolite and the toxicity that comes with it. So for years, ethanol is actually the answer for this because alcohol dehydrogenase prefers ethanol 4-to-1 over methanol and 8-to-1 over ethylene glycol. And to achieve this blockade, you need to have ethanol levels roughly greater than 100 milligrams per deciliter, and they were using IV continuous infusion. But then fomepizole came along. which has an insanely higher infinity for these toxic alcohols, almost 80,000 times greater. And this is easier to do. Its dosing is done Q12 hours, IV, boom. Although one thing you need to keep an eye on if you do start folks on a fomepizole treatment, you're going to do a 15 mg per kg load, and then you're going to jump to a 10 mg per kg Q12 hours, and you're going to do this time 4 doses. After those 4 doses are up and you're still treating with fomepizole, you have to increase the dose to 15 mg per kg every 12 hours. And this is indefinitely for the duration of therapy. And this is because fomepizole auto-induces its own metabolism somewhere around 36 to 50 hours after starting therapy. So you have to keep that in mind. And also in mind with fomepizole, remember, you're blocking ethanol dehydrogenase, and this is only effective if you want the parent alcohol to metabolize, but you got to know where you are in your time point. So, it may be early on, it may be later on, or maybe you don't have an ethylene glycol or methanol. You might just have somebody who's drunk on ethanol or even isopropanol. And if you do that and you block them, you're just prolonging their buzz. If you want a cheap night out, like get dosed with some fomepizole before you hit the town. So keep that kind of in mind. The other thing is that when you have a patient that has ethanol on board, this greater kilograms, so a blockade fomepizole around, if I have, level higher than that, 100, I like to do it around 150 milligrams per deciliter. And that's so you give pharmacy enough time, to get it made, to get it down to the patient and get it started. And if you're far above that number, let's say your patient comes in and, he's got like an ethanol level like 400, you're like, okay, I have some time now. They're effectively blocked, but, how much time until what labs can I do? How much time? And I usually go with somewhere around metabolize about 20 to 25 milligrams per deciliter per hour for quick, easy math. It's going to be dependent on the person and how often they drink. But I generally use that to kind of guide me so that when I get to that 125, boom, okay, I'm ready. And I'll trend those ethanol levels based upon my just estimations. The last one that we have is hemodialysis, and whether it's a parent alcohol or it's a toxic metabolite, HD is going to straight yank that out. Was it eat? Is that what the kids are saying nowadays? Eat it. Typically, this is going to run in 4-hour sessions is tolerated. Sometimes you have to do more than one session. A lot of folks will need it. Your patient's also going to be, being blocked with the agent that's also dialyzed out. So you got to think, whether you're using ethanol or fomepizole, you're going to have to dose adjust. And if you're using fomepizole, to have good directions on how to do that in regards to hemodialysis before, during, and after, how you can make sure your patient's going to be blocked effectively. So, when you're thinking about whether or not, hemodialysis needs to be started, there's 2 things. One, you can call poison control. You can come speak with us. Your tax dollars are paying for this. This is a free service for you. Well, not for, I guess, it's free, but, your tax dollars are paying for it. We can help you kind of go through the case details and see if and when your patient may benefit from hemodialysis. Secondly, you can just check out the XTRIP guidelines, xtrip-workgroup.com. And this is a set of guidelines where a group of toxicologists and nephrologists got together. They reviewed a whole bunch of literature, and they came up to provide recommendations of when to perform hemodialysis in methanol and ethylene glycol exposures. I'll let you check them out on your own. They're quite detailed, but they do have a lot of considerations regarding hemodialysis, when should it be started, and then when to stop it. But I'll give you 2 off the top of my head of when you should start, no question, like every single time. For me, knowing methanol has those serious CNS effects that can happen, thinking about the basal ganglia and the putamen and the hemorrhages and all that stuff. For me, if I have one of these patients and we have a suspicion or we know it's going to be a methanol exposure, we start the block, and I'm talking about dialyzing these folks immediately. And I call nephrology. I say, hey, I have a patient that needs a dose dialysis. Here's what's going on, and then we go from there. Very aggressive with those folks. For ethylene glycol, If you have a patient that has, pretty advanced CKD or really terrible AKI, you're going to need to block and dialyze them as well. And this is just due to the prolonged renal elimination that's going to occur. In the past, there's been, a lot of folks have been able to do, with ethylene glycol, they've been able to be blocked. There's a couple studies looking at this, and they do fine with it. But if you have really, really bad AKI, you're going to have to get nephrology involved and toxicology to kind of help you make that decision, because there are some finer points with that. And whether you're doing hemodialysis or fomepizole or ethanol, I generally, you get to a level of less than 20 milligrams per deciliter, regardless of what alcohol it is. Some will say 25 for one, some will say 20 for the other. I just use 20. It's a good safe number. So treatment is pretty straightforward, right?
Yeah, that makes it a little easier for the guys like us. So you guys have all the stuff in you guys' brain. So
yeah.
All right, that really hits kind of the high points of treatment for the most part of these agents. Anything in addition that we should do differently depending on these alcohols as far as the different treatment options, or that's pretty much kind of our big tool, a bucket of tools that we would use for all of these agents?
Those are the big ones. So yeah, you're going to want to be able to block, and it depends on where the patient's at, and then then we have hemodialysis. Those are the big things. It's block or pull it out is what we have. Yeah, those are the big things.
Perfect. Yeah, I love it because it's a cool thing, and you got all these different color urines and stuff like that. You got all this stuff going on, but it's easy to put a nice little fomepizole. And I always say, they always ask me, why is there beer in the pharmacy? It's like, well, it just depends on what we have going on here. So if you don't have fomepizole, it's like, well, I've actually heard somebody from a poison control center in a rural area say, hey, you guys don't have, you don't have beer, you don't have access to it. It's a blizzard outside. Use hand sanitizers. And I was like, whoa, okay, that's getting out there.
No, we've done it, and I've had cases where we don't have anything. The place is in a dry county, and it's this like little clinic, and we've done the same thing too. We're like, hey, what hand sanitizer do you have at your facility? And we're going through package inserts, or I've had nurses go to their homes. We've had this. We're like, we go to your house. We know they have alcohol there, and they've gone to their homes. They've brought their stash of booze back, and there we go. We're dosing the patient with that until we can get them transferred to better definitive care. So yeah, these things happen for sure.
Absolutely. Well, again, that was all super informative, and people are going to use this in different ways. But any final thoughts about this? Because again, I think it's a cool topic, but it's one of those things where, for you guys, this is like bread and butter. We found out what it is. It's nice to think about it. It's pretty easy to treat for the most part. But any final thoughts?
Yeah, history is a big part of what we do in tox, and I harp on this with a lot of things. History is so important. How was the patient found? Where were they? What were they doing? Have they done anything like this before? I've had, where the EMS comes in and go, yeah, we picked them up at Walmart. They were drinking, antifreeze in the aisle. I've had this happen a few times, actually. Or they're found down next to the actual containers, or yes, they have done this before. So get the history too, because history is going to tell you a lot, because, whether you're starting fomepizole or transitioning to HD, this patient's going to be getting a lot of, expensive supportive and antidotal care, but they can also progress potentially to something that's going to be really bad. And that's why, we can be very aggressive with these things up front. So history is so critical. And we want to kind of have an idea if, where are we in this toxicity? Because sometimes these patients just come in, they're obtunded, pH is 6.6, they're intubated, and that's it. That's all we have. That looks like a lot of things. That can be a lot of scary things to come in through your ED. So we always try to get that history. And if that big trouble is at your doorstep and you think you really have this toxic alcohol, call poison control. We will help you sift through all this little things you need to consider, some monitoring, and when certain therapies might be of use, and what adjunctive therapies could potentially be helpful. But in general, if you have a toxic alcohol in your differential, I have a low threshold for starting it. It's one of those things where I've never regretted starting fomepizole, because once you start it, boom, you got yourself 12 hours. You got 12 hours to get labs. You got 12 hours to get more history. You can get your patient fluid resuscitated. You can trend some labs. You can trend that osm and anion gap. and ethanol levels, and DBGs and lactates and all that stuff. So you buy yourself time to really do some more detective work and hopefully get the patient going where they should be.
Absolutely, man. I thank you for coming on and talking to us about this. This is another one of those great episodes where I just feel like I'm just so happy to be part of this podcast. We get so much information, and hey, people are going to use this to study. People are going to use this for patients. So you just never know how this is going to go. So I appreciate you coming on for talking about all of this stuff. All the information we have here is going to be on our show notes. Anything that we have, you guys can always reach out to us. But I'm going to close it out the same way I close out every single episode, guys. You don't have to be a pharmacist. You're not working at ED, but everything you do, make sure you farm so hard.
Closes it. Ozzy scratches his head. Whatever she's looking for, it isn't in there.